Thank you, Samin. Uh, Dr. Kinney, thank you. Dr. Bott, thank you for inviting me. It's always a pleasure. This is home, so it wasn't that much of a commute to get here. What I'm going to do is we're going to shift gears, but not really, because there's actually been quite a lot of overlap, if you haven't noticed, right? And some of the top 10s you have heard before. I'm going to perhaps give you a little bit of context. Here are my disclosures. We're going to talk about a different framework to anchor or interpret some of the data we're going to go through, and that's cardiometabolic-based chronic disease. You see, chronic disease is really the issue, and in fact, most of our patients have multiple chronic diseases going on at one time. Maybe 80% of people over 60 are going to have two or more chronic diseases. I'm going to divide the top 10 into first obesity. We'll split them halfway, 5 for obesity, 5 for type 2 diabetes. But I'm going to curate these papers in terms of what's pragmatic. So there's a lesson that you can actually take right back to your encounters with patients. So here's the model. Rather than looking at cardiovascular disease in isolation, each of the cardiovascular diseases and their own mechanisms, what we've done is we've looked at these cardiovascular diseases in terms of drivers, key mechanistic drivers, physiologically. And in fact, when you look at metabolic drivers and cardiovascular disease, hence cardiometabolic, you find that you're talking about atherosclerosis, atrial fibrillation, and heart failure. What we've done is we've built up models. Instead of saying obesity, which is stigmatizing, we use it in terms of abnormal adiposity, which incorporates ectopic fat and an abnormal adipocyte secretome, and adiposity-based chronic disease, actually been adopted by the Europeans as part of their guidelines. For diabetes, instead of looking at prediabetes in isolation or insulin resistance in isolation, putting them all under the umbrella of dysglycemia-based chronic disease. The two intersect, you can see on the right side where the orange is, they intersect at this key point of insulin resistance. And then everything feeds forward down to 4 stages of the chronic disease: risk, pre-disease, disease, and then complications. And ultimately, the goal is complication-centric, to prevent these complications. And you want to start as early as possible because of this exposure effect. All right, let's get rolling. We don't need our seatbelts. We got 10 papers to go through for the top 10. Let's first talk about intermittent fasting. I'll beat everybody to the punch because that's always a question. What do you think about intermittent fasting, right? What do you think about ketogenic diet? What do you think about all of these things that you read in Vogue and Cosmo and on the web? Well, here's a paper that came out looking at 4 to 3, and it's 3 non-consecutive days of, it's not absolute fasting, 80% restriction, and compared to, in the comparator group, daily caloric restriction, about 34% on average each day. Randomized controlled trial, 165 patients, 18 to 60 years, overweight to obese, looking at the BMI, and a 1-year study. They had high-intensity comprehensive behavioral and exercise, so that's for both groups. It's an intent to treat analysis. There was a dropout of about 24%. This is not really a representative population. You can see in terms of male, female, and ethnocultural populations, not really generalizable. The patients with the intermittent fasting consumed less energy. Here's how I put it together. It's a potential tool, but really unproven in the long term. So if you have a patient and you're just not able to get anything done, this may be a tool to jumpstart the process. And it applies, in fact, not only just for weight, but the ADA has this in their standards of care. So if you need to get somebody controlled from a diabetes standpoint. So it should be in your armamentarium, but I would not put this in the bin of some long-term intervention. All right, we got 4 papers for tirzepatide, followed by 2 papers on semaglutide. These are the questions that everybody asks, and everybody is writing these drugs. I've just been tasked to chair a guidelines on muscle loss for the incretin mimetic drugs by the DNSG Diabetes Nutrition Study Group of the European Association for the Study of Diabetes. Hot area, right? So let's sort of go through it. This is the SURMOUNT-1 paper from the investigators, New England Journal of Medicine, looking at patients who had pre-diabetes, looking at diabetes prevention with tirzepatide. So it's a subgroup analysis, 176 weeks. It was during COVID, so there was a pretty decent dropout rate. Intent to treat analysis, and there was improvement. There was a benefit in terms of primary prevention. Patients without disease, they had pre-disease, and decreasing the rate of converting into disease, and that was with tirzepatide. So 3 years of treatment with tirzepatide in persons with obesity and prediabetes. So these aren't patients without obesity, patients with obesity and prediabetes, and substantial and sustained weight reduction and a lower risk for progression to type 2 diabetes than with placebo. Bear in mind, different ethnocultural populations, you have different conversion rates. Right, you go to MENA, Middle East, North Africa, you have very fast conversion rates. South Asia, Southeast Asia, very fast conversion rates. Here in the US, relatively slow conversion rates. So these kinds of studies need to be replicated in different populations. A head-to-head study, how often do you see these? Tirzepatide compared to semaglutide, our DREAM study, what we really wanted to see. We want to see whether it's more efficacious, and we want to see if the difference of side effects. Let me just give you the long and short of it. There was more weight loss and there was more reduction with A1C with tirzepatide, right? And you have two brands of tirzepatide, one FDA approved for type 2 diabetes, one FDA approved for obesity, the same with semaglutide. If you look at the GI side effects, so this comes up, and this is part of the nuance when you talk to patients, right, about the GI side effects. Actually, there were less of the GI side effects, 2.6% compared to in tirzepatide, compared to 5.7% 2.6% with tirzepatide compared to 5.7% with semaglutide. So less GI side effects with the tirzepatide. So you had more weight loss, more A1C reduction. But how do you put this together? We have a thing called insurance here, right? So yeah, we would love to use tirzepatide. You get your pre-authorization back. Either it's not covered or their copay is still like $1,700 a month, right? And it's a problem. So you need to first, I got no problem starting with the tirzepatide, but then you have to be prepared and let the patient know up front. You're going to work with them. You're going to run all the different options. There's a Lilly Direct option. There are different pharmacies you can go to. The nurse practitioners really need to be trained and develop an experience getting these drugs. We're pretty successful, but it does require an army behind every clinician to get this done. You've already seen this. Dr. Mera presented this tirzepatide for heart failure and preserved ejection fraction and obesity. So the key here is these are patients with obesity. We'd love to see this study done in patients with lower BMIs, right, who didn't have the ostensible indications for the incretin mimetic drugs. But in these patients, 48% had type 2 diabetes. You saw a reduction in CV mortality. And what we're going to do is we're going to see more of these studies for other things. We already have it for sleep apnea, but we're going to see it for addiction, for cognitive dysfunction, for cancer, for peripheral arterial disease. There are a host of other conditions that, for the pleiotropism of these drugs, that are going to be emergent. Lastly, for tirzepatide, I want to talk about muscle. It's very important to understand this concept. There's a lot of banter that goes around on the internet, and you hear it maybe in lectures, you hear it in some conferences, that these drugs cause muscle loss, right? And that you need to have higher protein in your diet, you need to have progressive resistance training. Well, let's look at the data. What's actually happening is, yeah, the volume of the muscle goes down, but that's probably because of successful and desirable mobilization of the ectopic fat that's in the muscle. That ectopic fat comes out, the muscle function improves, but cosmetically or in front of the mirror, the patient's going to say, I have less muscle. When you examine the patient, less muscle, you need a hand grip device in your office to follow muscle function. Now, we need more studies to look at this. There are not that many studies as here with MR. We need better imaging for muscle. We need to understand this physiology better. We have some retrospective studies, registry data that confirm this, but it's not hard and fast. We also need to know what the optimal lifestyle should be for patients on these incretin mimetic drugs. And you know what? What's really important? Should we be de-escalating these drugs? I could argue that actually we should be. Contrary to what you've heard, that they're on it for life, maybe we should be escalating lifestyle to allow us to reactively de-escalate all of this pharmacotherapy. And we need data for that. We need to have medicines and we need to have strategies and tactics on how to prevent the weight regain as we de-escalate and withdraw these medicines. Those are the research gaps. Cagrilintide, semaglutide. Cagrilintide is an amylin antagonist, and it binds the calcitonin receptor as well. This is a combination medicine. Basically, I included this study because this is coming out. There's a whole pipeline of more incretin mimetic drugs. There are going to be drugs that are going to have anti-sarcopenia agents on it. Glucagon's going to be on it. And all these drugs are in the pipeline. The older drugs are going to go generic. That's going to satisfy and solve a lot of the socioeconomic issues. But you can see here you had relative parity in terms of weight loss and A1C reductions with tirzepatide. Moving on, this is looking at semaglutide and cardiovascular outcomes in high-risk patients with type 2 diabetes. And with atherosclerotic cardiovascular disease and type 2 diabetes, also with chronic kidney disease, oral semaglutide is now showing this benefit. So if you recall, when all the CVOTs came out, we really didn't have oral semaglutide show superiority. There was non-inferiority, but not superiority. Here we have a little bit of superiority. Not much, but it's there. Efsitora is going to be a new insulin. We're looking at the end of 2025 for it to go to the FDA and then get approved. This is a weekly insulin. So it is an option now for your patients who have decreased beta cell reserve, right? And you want to come in with insulin where there may be some adherence issues. In general, as endocrinologists and as cardiologists, we really don't want to have so much insulin on board. It's anti-lipolytic, it's harder to lose weight, there's some atherogenicity associated with it. But if you need it, if there's decreased beta cell reserve, if it's late in the course, you're burning out the beta cells in type 2 diabetes, a lot of patients are just simply not going to do multiple injections a day or even daily injections. So this is an option. Keep your eyes out for this one. Non-inferiority study compared to glargine. This is an interesting study looking at chronic kidney disease in patients with type 2 diabetes. A lot of us, our common practice is maybe to add an SGLT first, think about finerenone, and sort of do them in a stepwise pattern. Here's a study looking at introducing both of them at the same time, initially, and showing some benefit in terms of blood pressure and GFR in microalbuminuria. The potassium elevation was there. It was a little bit, it wasn't statistically significant, but this was, I thought, a very interesting study and something that may impact some of your practice patterns. We're going to move into 10A and 10B, right, to close it out, and this is on lifestyle. So to the left, this was a study I had just, when I was at EASD, and the paper had just come out and we were reviewing it. So this is an extension looking at the DPP trials, but all the way out to 21 years, right? And seeing persistence of that sustainable benefit, metabolic memory and legacy and all of that. But this is having a benefit going out to 21 years. Now, yeah, the curves are converging for lifestyle and metformin. Remember the 58% versus the 31%, they're converging going out to 21 years. But lifestyle on metformin really having some of that long-term benefit in terms of primary prevention, decreasing the conversion of prediabetes to diabetes. Then on the right side, Jordi Salas had sent this to me right after we were meeting in June. This came out, looking at the Mediterranean diet, and PrediMed Plus versus the standard PrediMed. And standard PrediMed really didn't have that reduction in calories, but the PrediMed Plus had a reduction in calories and had a pretty sophisticated, comprehensive physical activity program, which actually also included flexibility and balance studies, decreased proprioception as we grow older. And actually, there was a nice benefit showing reduction in diabetes incidence in people who had overweight, obesity, or abnormal adiposity. All right, let's go through our conclusions. Running ahead of time, I'll give you some minutes back, Samin. This year's top 10 are interpreted in the context of this cardiometabolic-based chronic disease, not looking at a particular state in isolation, but rather imagining all of those early drivers and exposing opportunities for early and sustainable prevention, not waiting and waiting. Intermittent fasting is safe and efficacious, but still relatively unproven in the long term. We really don't have those long-term studies, but it is a valuable tool to keep in reserve and have in your armamentarium. Tirzepatide, if you look at the available incretin mimetic drugs, looks like it's performing the best in terms of benefit, weight, A1C. Also, you've heard about blood pressure, you've heard about benefits on cardiac function, and we have sleep apnea. There's innuendo and observations about addiction. I actually have 2 patients I've started with alcohol abuse disorder, and there's data on that. The cancer issues are emergent. There was a little bit of a scare among the endocrine field about an increased risk of thyroid cancer. Turned out it was an epidemiologic artifact. We're just looking for it more. A lot of people are doing ultrasounds, and everybody they're starting on the incretin mimetic drug. So yeah, there was a blip. You control for that. There's no increase in thyroid cancer. The medullary was in the murine model. So there's no real reason to go ahead and order calcitonin and get ultrasounds unless there's an established or family history of MEN or medullary carcinoma. But tirzepatide, and that, by the way, applies to all the incretins. Tirzepatide looks better, but you need to have that infrastructure so there's no practice gap. You need to have your team ready to go through all the insurance. Cagrilintide, amylin agonist, a promising incretin mimetic drug. I think I said antagonist before. Agonist, a promising incretin mimetic drug for abnormal adiposity and dysglycemia. It'll be coming out along with others in the pipeline. Oral semaglutide now showing some superiority, not just the non-inferiority from the prior CVOTs, and useful to reduce cardiovascular events in high-risk patients. So this was what was different about this study is it was high-risk patients. They did have chronic kidney disease. It was a longer-term study, so they were following patients for more time. Efistora is a newer weekly insulin and to be considered in select patients, particularly those who may have some issues with adherence. Think about starting both finerenone and EMPA, or not just EMPA, but an SGLT2 at the same time to reduce CKD progression, and again, in these patients with type 2 diabetes. Lifestyle intensification, practice gap. We need to develop more structure to be able to implement the lifestyle intensification, but the data are there with or without metformin, and for realizing some of those sustainable benefits in preventing type 2 diabetes that now are borne out by the 21-year data from DPP that I showed you. PrediMed Plus, having that caloric restriction with the Mediterranean diet and comprehensive care, including physical activity, progressive resistance training, aerobics, flexibility, balance study, really seemed to help out in mobilizing some of the ectopic fat, decreasing abnormal adiposity, and general health. So with that, I'll stop. I think we have, you got some of your time back, and I'm available for questions. Thank you.
So I have actually, there's a question here. Once target weight is achieved, should GLP-1 and agonists be down titrated to attenuate risk of rebound weight gain and sarcopenic obesity rather than stop abruptly?
Yeah. So the question is about de-escalation and what do you do? And we don't really have guidelines that help us with that. Hopefully these will be forthcoming. I'm a big proponent of de-escalation, particularly for pharmacotherapy. We just included a chapter in our latest lifestyle medicine book. There are two kinds of de-escalation. There's preemptive, where the patient just really doesn't want to be on the medicines. You spell it out, okay, this is what you're going to need to do. You start cutting back. It's up to them to escalate the lifestyle. The other is reactive. So if you consider Michael Lean's study, Roy Watson's study with DIRECT, right? Every single person, when they entered DIRECT, all the blood pressure medicines were stopped preemptively. Because we know when you start losing all of that weight, all of a sudden the patients are getting dizzy and pre-syncopal because there's too much blood pressure medicine on board, so you preemptively lower it. So my bias is that when I'm starting an incretin mimetic drug, and this is more for weight loss, not so much for diabetes. Diabetes, they may need to be on it long term, but for the weight loss, I will put it out there. And they'll ask, am I going to be able to come off of this? How long do I need to be on it for? You all know that. That's the first thing that they say. And I'll give them that opportunity to step up the lifestyle. The other thing is we don't live in a binary world. Why can't they de-escalate? Something happens, they go on a cruise and there's some stress in their life, then they can re-escalate. What's wrong with delegating some of this to a patient-centered care, right? But we need to have the evidence to support that. As far as the muscle goes, this is actually one of the arguments in favor of the new high-dose semaglutide oral that's going to be coming out. And one of the markets is going to be, you have somebody on injection weekly, right? You want to de-escalate, get them off. You can then flip them over to the pill. And now it's a little bit easier. They feel like they're accomplishing something. But then you could even de-escalate that. I just want to throw in, you've all heard the term microdosing. There's no such thing as microdosing, right? But what they really mean is you can delegate to the patient. You don't have to do it every 7 days. It's not biblical, right? You could do it every 10 days, every 14 days, as you want to. But as long as there's medical supervision, that's the important point. The doctor needs to be involved.
Yeah. So actually, I see many patients, they do complain that on Ozempic, which is the semaglutide, the weight they did not lose the weight, but on tirzepatide, Mounjaro, yes, very consistent weight loss. Any mechanism or any reason for it?
Yeah. So the point is there value of switching from SEMA to tirzepatide, or even in reverse? So if you have somebody with adverse effects, sure, you can switch. There's no guidelines what dose. Usually I'll take an intermediate dose of tirzepatide to a maximum dose of semaglutide. So if there's adverse effects, you can switch both ways. But more often than not, somebody is on their max dose of semaglutide. They're not really getting the target weight loss we want. You've intensified everything else. I'll switch them to tirzepatide, and more cases than not, they will succeed. Mechanism. So it turns out that the GLP-1 will suppress glucagon. In tirzepatide, you have the GLP-1 and you have the GIP, gastric inhibitory polypeptide. And the GIP actually nudges up the glucagon a little bit. We all thought maybe the glucagon going up, that was causing the proteolysis and some of the muscle loss, probably not. But if there's going to be a mechanism, that could be one of the mechanisms, is these subtle changes in glucagon, which, by the way, that's why these triple incretins that are coming out glucagon's going to be part of that. You'll be seeing them in the next year or so.
Okay, few more questions came up now. Do the weight loss medication need to be stopped prior to surgery or interventions? If yes, for how long?
Right. So this is actually an easy answer. The real answer right now is probably a week. A lot of people are very nervous. The anesthesiologists, they like 2 weeks. There are some guidelines that say maybe 3 days before something minor. The problem was there were some patients that had some gastric content, and everybody was getting nervous, and 1 week was this arbitrary, you just skip one dose. And then some centers institutionally said, 1 week, we don't really feel comfortable, let's make it 2 weeks. They go back on it afterwards. You need to just inform the patient when you start that if they have a procedure, to ask the doctor whether they should be stopping it or not. Some endoscopists may have their own rules, so it's really important to advise the patient to discuss with the treating physician what their rules are. But 1 week to 2 weeks.
Okay. So another one actually addressed to us. That too many doctors used to smoke, but now stopped. Is there data that physicians are healing themselves and losing weight? I don't know losing weight. I don't think physicians are losing weight, but smoking, yeah.
Yeah, there's something called for obesity, I participated in a paper with some colleagues at Columbia on the hormonal versus the hedonic model of obesity, right? So hormonal, we know what all that is with the hypothalamus. But there is this hedonic model that there are pleasure centers in the hypothalamus, and you take away one pleasure, you need to make it up with another pleasure. So you take away the smoking, notwithstanding the nicotine and nicotinic receptors and other things, and all of a sudden, food-seeking behavior and appetite and MC4, melanocortin-4, everything gets revved up, and you have orexia, more appetite, and the weight goes up. There is more of a public awareness, right? There are less physicians smoking now, and less physicians walk. I mean, back when I was in medical school here, you could smoke on the floors. I mean, there were physicians literally smoke. I remember at Texas Heart, actually it was Methodist, Houston Methodist, a very famous aortic surgeon, right? Used to come by and round in the DeBakey ICU, 103 beds with this cigarette, just flipping it on, everything moving. That was his rounds with the cigarettes in the ICU. So times have changed. This is behavioral economics. How much does a pack of cigarettes cost, right? And this is just culture. And why can't we replicate this for our food and for other behaviors and supersize me and running paths and urban infrastructure? We know the theory. Why are we unable to implement it? And we've written some papers on this. This is probably, we need more legislative acts, ultimately. That's another talk.
Good. All right, if any other questions, if with that note, we conclude this fantastic
Great. Thank you.
education.